Now this is the aortic waveform that you want. You've got a peak pressure, that's the peak, and then you've got dicrotic notch. These are very important to see. Now, can you use side hole catheters for performing FFR? Well, the problem with side holes is that the pressure that you get from the catheter tip is not that accurate then, because you're getting pressure from the side holes and it is affecting the pressure which is there at the distal tip. So that's why it's written that this PA is equal to PC. That's not possible. These two pressures cannot be equal. Therefore, it's better to avoid side hole catheters while recording FFR. Now, if you are still going to use side hole catheters, then it's important that you do the normalization and recording of FFR both with the guide catheter disengaged. And the other thing which is important is that you cannot use intracoronary adenosine with side hole catheters, because a lot of this adenosine is going to leak out of the side holes. So it's important to use IV adenosine infusion if you are using the side hole catheters. Now, again, it's very important to see the waveform. Just don't rely on the numbers that you're getting from FFR. The number is only reliable if you know that the waveform is perfect. So look at this waveform. That's how you want this waveform to be. That's the aortic waveform. It has a dicrotic notch, and then you can see this is a V shape in between the two waves. So this is very important. This V needs to be maintained. Now, if you look here, the systolic pressure has gone down, dicrotic notch has disappeared. Now, this is dampening. This is dampening of the pressure. The systolic pressure is artificially low. There is no dicrotic notch. This means the guide catheter is wedged and you need to pull it back. It occurs mainly in the left mainstem lesions or the ostial right coronary artery lesions. So what actually happens is, that's the guide catheter wedging against the wall, and what this does is that the PA, the catheter tip pressure, that's the PA, artificially goes low because of this wedging. So when you put it into the equation PD over PA, where the PA is low, what you get is a falsely high FFR. So the stenosis severity is actually underestimated if the guide catheter is wedged. So you need to pull your catheter back and correct the waveform first. Now, the other thing you want to look at is the transducer height. The transducer height has to be at the heart level, that is the mid-axillary line level. So this is the correct height which is shown here, and the other two heights are incorrect. So what happens? If you move the transducer higher above the heart level, the PA will go lower. And if you move the transducer below the heart level, the PA will go high. Now, in a live motion, what I've tried to show here is that when I'm moving the transducer high, look at the aortic waveform going down. And now if I move the transducer down, look how the aortic waveform is going up. So this is what happens when the transducer is not at the exact heart level. So this has to be corrected. The next thing you have to do is you have to zero your wire, but before that you flush your wire. That's the first thing you do, and then you connect it to the once the wire is flushed, you connect it to the machine. When the machine says wire is zeroed and ready to insert, then you take the wire out. This is just showing you the zero calibration, and then you take the wire out, you put it through the introducer in the Y connector, you make a tip of you shape the tip of the wire, and now you are ready to take the wire in. Now when you take the wire in, now is the time to administer nitrates, because you must remember that FFR and IFR both require nitrates. So at least 200 to 300 microgram of intracoronary nitrates are given. It usually takes about 30 seconds to act, and the effect lasts for about 20 to 30 minutes. And this ensures that the epicardial coronary artery is maximally vasodilated. And now IFR is adenosine free but not nitrate free. So remember, nitrate has to be given for both FFR and IFR. Adenosine is only given for FFR. Now you've given the nitrates, you're taking your wire in, your wire is in the guide catheter now. Now is a good time to flush your guide catheter with saline and confirm adequate aortic waveform. Your contrast must not remain hanging into the guide catheter, because it gives an impression of a damped guide catheter if the contrast is still there in the guide catheter. So give heparin to maintain an ACT of more than 250 seconds throughout the procedure. So no more contrast injections. You've got a roadmap in front of you without taking further contrast. Now take your wire into the guide catheter, and then you take it further till the time your wire comes out and the junction of the radio opaque with the translucent wire, that's where the pressure sensor is. So this point has to be just outside the guide catheter tip, and now you are ready for normalization. But before you normalize this, you've got to remove your introducer which is in the Y connector. Why you want to remove it? Because there will be artificial pressure leakage from this, and the PA will slightly go down, which may affect your FFR or IFR. So just to show you that there are two types of introducer needles. One is with the yellow hub, one is with the transparent hub. The yellow hub is a slightly thicker one, and therefore more blood can leak out and more pressure can go down with the yellow one as compared to the white one. And that's to show you the impact of keeping the introducer in the Y connector. You can see that when the introducer is in, you can see the difference that has come in. The PA has gone down, and that's the amount of difference that it made. But if you use the transparent one, the difference is much lesser as compared to the yellow one. But the ideal situation would be to remove this introducer and then do the normalization. But in case you forget to remove this introducer and you normalize the wire, and you've taken the wire down for FFR measurement, now don't remove the introducer, let the introducer remain in, because you've normalized the wire with the introducer in. So now FFR reading will also have to be done with the introducer in. So this is the normalization picture. Wait for 10 seconds after the saline flush for contrast to lose vasodilating effect, and then normalize. So the contrast causes a vasodilatory effect, and we will wait for that to finish off, which was a few seconds, and then press the normalization. Make sure that when you do the normalization, your PDPA will come to 1, but at the same time there has to be complete alignment of PD and PA waveforms, and not only in the magnitude wise, height wise, but also the temporal alignment has to be perfect. The other thing is that the aortic waveform has to be a proper V-shape here with a dichrotic notch. This is very important. There should be no dampening of the pressure waveform. So two things to look out, just as I described, PD-PA ratio must be 1, and even if this is 1, but if you look at the waveform here, they are not perfectly superimposed on each other. There is temporal misalignment. So this needs to be normalized again. So press the normalization button again till the time these two waveforms are perfectly superimposed on each other. Now the normalization is perfect. PD-PA ratio is showing 1, and there is correct temporal alignment of the waveforms as well. So this is again just to show you that here the dichrotic notch you can see, but you can see that the PDPA is 1.03, so this is not perfectly normalized. So now you have to again press the normalization button so that these things normalize. So good ECG signal is essential for IFR. We know that IFR requires to calculate these reading, the number in the wave-free ratio during the diastolic phase. So that is only possible to calculate with the artificial intelligence software fed into the machine if there is a good signal of the ECG. So FFR is not dependent on ECG, but IFR is dependent on ECG. You've got to have a good ECG signal on the IFR machine. Now, once the normalization is done, you will advance your wire and the pressure sensor will go ahead of the stenosis. How far you should go? You should go at least 3 vessel diameters ahead of the stenosis. So vessel diameter and multiplied by 3, go distal to that. But ideal would be to go as distal as possible so that the whole length of the coronary can be assessed for significant ischemia. So once the wire is there and you are doing an FFR, then in IFR there is no problem. Now you are ready. You just press. You've given the nitrates. Normalization is done. Wire is down below the distal to the stenosis. Just press the IFR button and you will get an IFR number within 5 seconds. Whereas for FFR, now is the time to give adenosine. You've got to induce coronary hyperemia. Adenosine will act on the microcirculation, whereas the nitrates that you've already given act only on the epicardial vessels. They don't affect the microcirculation. So there are ways of preparing intracoronary adenosine. This is a diagram just to show that. You have to hang these in your cath lab right next to your console for FFR. You can prepare adenosine infusion like this. So usually we give 140 micrograms per kg per minute, and the recommended route is central venous line. But if you're giving it from the arm, then it is preferable to give it through the antecubital vein at the elbow level with a large bore cannula, and then preferably increase the infusion to 180 micrograms per kg per minute. So it usually takes 30 seconds to 2 minutes. I've seen even 4 minutes maybe for adenosine to act. How do you know that hyperemia is setting in? So once the hyperemia starts setting in and adenosine is effective, you will see tachycardia coming in. That's very important. Tachycardia has to come in, and then you'll see drop in the blood pressure. And with this increase in heart rate and drop in blood pressure, you will also see that the transstenotic pressure gradient will start setting in. The PD waveform will start going below the aortic waveform. There will be a difference between the two mean lines, and if this stenosis is significant, there will be ventricularization of the PD pressure waveform. The patient at this time may start experiencing some symptoms like dyspnea, flushing, chest discomfort, palpitations, headache, or dizziness. You may get transient bradycardia because of adenosine or even asystole, but remember the effect of adenosine is very short-lived, so it's very rare to see anything significant there. It's usually a very short-lived bradycardia. Now you can see the LED here, and patient has received adenosine and the FFR is 0.58. I've still written here no FFR. Why I've done that? Because we haven't mentioned use of nitrates in this. If you don't give nitrates, you don't remove the epicardial spasm. That is a possibility. So is this spasm or is this disease? So once we give nitrates, look how this artery has opened up. Look at the LED, and the FFR has now gone up to 0.78. So now this is nitrates followed by adenosine. This was adenosine alone. So this is not FFR. For FFR and IFR both, you've got to give nitrates. And in FFR, then you need to give adenosine as well. Now this is just to show you again. Look at this waveform. Now if you have ventricularization of both the pressures, this is again deep-seated or wedged guide catheter. You need to pull it back. And once you pull the guide catheter back, now look at this. So just remember that this is a perfect gradient that you want. If you want to remember the shape, remember that the aortic or PA waveform should be in V shape. And if there is a good gradient there and it's a significant disease, there will be proper ventricularization of the PD waveform, V and U. This is the U shape here. So the PD should be in a U shape, PA should be in a V shape. That is perfect ventricular. That is a perfect gradient here. Now suppose that this is also U shaped, the PA. Like in this case, this is not good gradient. This is not a good reading. Whatever number you're getting, that number is not correct. That's a false FFR value because this is wedging of the catheter. The third situation that is possible in this scenario is waveform drift. What happens in drift is you've got a gradient here. There's a difference between the red and the green line, but the green line is also in a V shape. It's not a U shape. So if you have a gradient difference between the two, but the two are both in the same shape like a V, this means this is a drift. You've lost your normalization which you did at the guide catheter tip. You've got to go back, take the wire back to the guide catheter tip, do the normalization again, and then come down again and do your recording. So in drift you can see not only the V shape is maintained, but the dicrotic notch may also be maintained. So flush the wire as the first step. While opening the wire, that's very important. The other reason for drift could be temperature change. So once these things happen, go back to the guide catheter tip and do the normalization again. Now, it's again very important, you don't look at the FFR number alone, you also see where that FFR number has been calculated, because the system automatically calculates FFR at the lowest number possibility and shows you that number in the whole recording. Now in the whole recording, FFR has been calculated at this point because this was the lowest FFR and it came out to be 0.49, but you can see here that there is a VPC. There is a ventricular premature contraction, and that's where the FFR has been calculated. So now you've seen that it's at an artifact. So now you've got to move it away manually. So you manually move it away and keep it at a point where now the FFR lowest is 0.64. This is the right FFR and not this one. What's happening here is called whipping. So the pressure sensor is actually coming in contact with the coronary walls. So what you need to do is, if you see these large size PD waveforms coming up, you've got to move your wire sensor forward or backwards so that it loses its contact with the coronary wall, and then these waveforms will stabilize and these spikes will disappear. So once you've done the whole recording, your number is still not verified FFR number unless you confirm for drift. One drift I showed you that if the FFR number where you're getting it, if the two waveforms are both in V shape, that's a drift. You've lost your normalization. And then the other thing you have to do is now pull your wire back after recording FFR and take the wire sensor right at the point just outside the guide catheter tip where you did the normalization, and now see your PDPA. Your PDPA should now be 1. If it is 1, that means you did not lose your normalization and your FFR number is correct. A margin between 0.98 to 1.02 is acceptable provided you don't have an FFR which is right at the borderline. So this 0.02 margin plus minus can be accepted, and the two waveforms need to be superimposed when you are checking for normalization the way you normalized it. So not only the PDP has to be 1, but the two waveforms also need to be superimposed. Otherwise, if you lose your normalization, if there is a drift at this point in time, you have to normalize your wire again, take it back again distal to the stenosis, and do the recording again. So what are the steps to acquire a good measurement? There should be proper placement of aortic pressure transducer. The height has to be at the heart level. You must give nitrates. Ensure that there is no aortic damping. There should be proper guide catheter placement. Then you need to do proper normalization with PDPA to be 1, and the waveforms have to be superimposed upon each other. Then you take your wire distally to the stenosis and you induce hyperemia with adenosine. Once the hyperemia is in a steady state, then you acquire the number, and once you've acquired the number, you look at the waveform that the number you've got, the waveform is correct. And after that you check for drift by taking the wire sensor back to the normalization position, and you see if there is drift or not.